Good afternoon, everyone. I'm Eliza Norcross, a project associate for Plan4Health, and on behalf of APA, welcome to the second Planners4Health session, What We Measure Matters, Metrics, Data, Sources, and Methodologies. A few housekeeping items before we dive into the session. Please use the chat box if you have any questions or concerns throughout the webinar, and we'll do our best to answer them as they come in. At around 4 o'clock, we will transition into a conversation with the panelists and all of you, our participants. So throughout the session, think about any questions you might have or things you want to bring up to the group. And once we get to that piece, you can either chat in your questions or you can raise your hand and we can give you permission to jump in on the phone line and ask a question or engage in discussion that way. So I would now like to introduce our colleagues at the Prevention Institute. You probably remember them from last time. Rachel Bennett and Sandra Vieira are with us again, and they've been working very closely with us throughout the development of the Planners4Health curriculum. The Prevention Institute is a nonprofit organization building a movement to transform communities to support equity, health, and safety by bolstering the conditions and factors that foster resilience and well-being. Rachel works collaboratively with partners on research, policy, advocacy, and technical assistance related to healthy, equitable community development and health in all policies. She earned dual master's degrees in public health and urban and regional planning from the University of California, Los Angeles, and a bachelor's degree in psychology from the University of California, Davis. She is committed to promoting social justice through the framework of public health. Sandra is a graduate of the University of San Francisco with a master's in public administration and policy, and earned her bachelor's degree in political science from California State University, Long Beach. She works to promote safe and healthy communities through projects focused on improving the built environment, increasing equitable opportunities for physical activity and play, and increasing capacity across communities in the area of primary prevention. I'm now going to pass things over to Rachel and Sandra to jump into the session. Thank you.
Thank you, Eliza, and the APA team. It's so good to be back. How quickly a month can pass by, and I know for many of you, you're busy and engaged in the important work that you're leading in your different sectors and communities, and so we really thank you and appreciate the time that you're dedicating to be part of this discussion. And again, just to underscore that this session, like the other ones the other one that passed and will come, are really meant to present some important tools, frameworks, examples, current work being done that can help move your own priorities along and can help set us up for a good discussion with you all just shortly. So in building off of that intro, I wanted to highlight some of the things that as Prevention Institute and as folks who are really looking at this intersection between planning and public health, transportation, a number of different issues, is really some of the common threads that different disciplines, fields, sectors think about and use. And one of that really being data and the use of metrics and indicators and information to inform our strategies for change, since all of us are really into this work to create healthier and safer and more equitable communities. So I wanted to give you a story of an effort that we came across in some of our work supporting health systems, including community health centers, hospitals, et cetera, in moving more upstream from their sort of focus on services, emergency service provision or education, and really point to ways in which the information, the data, the context that they gather, from their clients and patients can really help to inform a broader community strategy. So I'll walk through a little bit of this story coming from Cincinnati and being focused on the Cincinnati Children's Hospital. So during a heat wave in the summer of 2010, doctors and physicians at Cincinnati Children's Hospital observed a spike in emergency room visits that they were able to pretty quickly identify as children having asthma attacks. And so, you know, the part of the information that was being conveyed and shared between physician teams was just how this was different than in other summers, and wondering kind of what that was about so that they could also prepare themselves to address that issue. So the team internally at the Cincinnati Children's Hospital found an opportunity to kind of collect additional data and to work with the public health department on geocoding the admissions data to identify where the children were coming from, and found hotspots. And those hotspots actually were within 19 apartment buildings within the city limits. In speaking with and really kind of listening to community residents, and also looking at different city records, an approach that they also brought in other partners to help them kind of queue up that next level information gathering, they learned, in fact, that all of the 19 buildings were owned by the same landlord. We'll move to the next slide just to give you a bit of a sense of what that geocoding looked like. So if we're looking at this map around the asthma admissions in late 2010, early 2011, you can see some clusters and some very, you know, red areas which indicate a higher prevalence of asthma admissions. And so in looking at that and working with our partners, learning more about their from community members, they were able to pan out really the picture and understand what was contributing to that. Part of what they found was that to avoid paying higher electrical bills, the landlord was handing out eviction notices to tenants who requested a window air conditioner. So as a result, families did without air conditioning, and asthma attacks skyrocketed. So the hospital, working with the local legal aid society, teamed up with community residents, with the public health department, with other coalitions, to address the housing problems that young patients and their families were facing. And as I mentioned, they worked with media to help tell the story and to use that data that they had collected and analyzed to really kind of present this not as specifically an asthma problem, but rather a poor housing issue in their communities, and really move more upstream. So this example really illustrates that evidence, data, information, et cetera, really comes in many different forms. The following model, which we are showcasing, comes from the Centers for Disease Control and Prevention. It came from some of their work around violence prevention, and really wanting to acknowledge that the best available research evidence, which is oftentimes what public health can focus on, presents one part of the broader picture, and that evidence-based decision-making should actually keep in mind contextual evidence and experiential evidence. So contextual evidence and experiential evidence sort of spanning things like you know, resident mapping of problems and assets, local city and county reports, community members involved in photo voice or video voice. And we're seeing more and more institutions, including the CDC, recognize this and expand their work to include multiple types of evidence. And because communities are so complex and there's so many issues and opportunities at hand, you know, the importance around incorporating a broad range of data into work really allows us to get a fuller picture of not only what the problem is, but to understand what assets exist to address the problem. The quote I wanted to share here that really comes from more of environmental justice angle, but I think is very relevant to the work that we all as a group are thinking about, is how indicators really help us think about problems and solutions and approaches. So the quote here is from Danella Meadows. It says, "The indicators a society chooses to report to itself about itself are surprisingly powerful. They reflect collective values and inform collective decisions. A nation that keeps a watchful eye on its salmon runs or the safety of its streets makes different choices than does a nation that is only paying attention to its GNP.
So this really underscores the point in the title of this webinar of what we measure matters. We also know, though, that data collection and disaggregation and analysis is not perfect, and that many partners in rural communities, for example, are only able to get data at a county level on health behaviors, health outcomes, planning conditions, and so on. Professor Bochwe is going to talk more about some work that she and some partners have been doing with the 500 Cities project to collect and disaggregate more of these data on a local level in cities. But we did just want to highlight the fact that in many places, and particularly in rural areas, that this does really remain a challenge, that this best available research data doesn't get down to the level of local inequities between neighborhoods. So we think that bringing in contextual and experiential evidence, asking people on the ground and community members and youths, what do you see, where are the problems, where are the assets, that we can really build out that fuller picture of both the issues and the opportunities. So we want to just underscore really that when you think about data and evidence, think broadly and think about how to paint that broad picture by including people who live the conditions that you're making decisions on each day. I think really this gets to the point of not just asking what is the problem and where is it occurring, but asking why is it occurring. And I wanted to just give a quick nod to our partners at the Build Healthy Places Network for doing a lot of background research on the story from Cincinnati.
Perfect. Thank you, Rachel. You know, that Cincinnati example really highlighted for me and for my colleagues and other partners around the different sort of dimensions that data and different types of evidence can provide. And so really thinking, you know, beyond what the data that we're used to navigating, but really asking those questions that go beyond sort of what the problem is, wherefore, or for whom, but really around why. And I think asking why things are the way they are can really help make data not only in informing, you know, the issue, but really helping to shape the solution and the action. And I know for Cincinnati, what, you know, came up for them after going through this process was that they were able to pick up patterns about social problems and contribute to the community that was solving them. So for them, it was really an opportunity to bear witness to the impact on children's health, but then look for the cure upstream and be part of that solution.
We talked in last session about identifying the levers of opportunity as you're doing an assessment of community conditions or of policy conditions and potential partners. And so using this more experiential and contextual data to supplement these research data that are out there can really get at that fuller picture of why, and then who needs to be at the table to address things, what those levers of opportunity are. The last thing that we wanted to highlight before opening it up to the other speakers is it's really important to be incorporating these multiple types of data, but also the process through which we do that is really important. And by including local residents in a community planning process, local youths, in a really intentional way, building capacity and seeding that sustainable change, that is the stuff of systems change. So for example, when you include young people in a planning process, whether it's photo voice to say, you know, which streets need to be made complete, or where are you seeing the greatest injuries, or where would you want to see a grocery store, or what are the challenges you face in getting to safe parks, all these kinds of things, not only will they point out things that you probably can't find on a map in a database from your desk, they also point to solutions, and they come to see that they can really be part of the process of changing conditions in their communities. That's creating leadership for the next generation. That is building capacity into the community to change the way decisions are made. Similarly, you know, here we are, Planners4Health national learning community, sharing strategies and ideas across different sectors. Working together, we are building relationships, we're building communication, we're building capacity here, and this is the stuff of systems change. This is how we are going to change the practice of healthy planning for this next generation of planning work. So again, going back to that importance of multi-sector collaboration and community engagement in everything we do, particularly in the collection of data and evidence, in the disaggregation of it, and the analysis of it. So just want to mention that we really do feel like that is the stuff that we are doing to change the way this practice works. We're going to come back to these ideas in a bit, but first it is my pleasure to introduce Professor Nisha Bochwe. She is an associate professor of city and regional planning at the Georgia Institute of Technology and an adjunct professor at Emory University's School of Public Health. Professor Bochwe holds graduate degrees in both urban planning and public health, and her research focuses on health and the built environment, health equity, community engagement, and data dashboards for evidence-based planning and practice. She has authored many publications, and she's the director of some really powerhouse institutes, including the Built Environment and Public Health Clearinghouse, and she co-directs the National Physical Activity Research Center. She is the recipient of more honors and distinctions than we have time to share right now, and we're really excited to hear about what she's been working on lately.
That's going to be great. And following Dr. Bochwe and Professor Bochwe will be Kim Irwin, who is the Executive Director of Health by Design, which convenes the Indiana Citizens Alliance for Transit, the Indiana Complete Streets Coalition, the Indiana Safe Routes to School Partnership, and Indiana Walk. So she's really big in Indiana, understandably. Through these coalitions, more than 300 organizational partners are working to ensure that communities throughout Indiana have neighborhoods, public spaces, and transportation infrastructure that promote physical activity and healthy living. Kim serves as a mentor and is on multiple boards and committees and is a dedicated leader of the healthy planning movement in Indiana. So we will welcome her shortly.
So I think this is where I pick up. So this is Nisha Bochwe. Thank you all for having me with you today. I am just going to make sure I can advance the slides, but it doesn't look like I can, so I'm going to ask Eliza if you would go to the next slide. Thank you. So I'm going to talk to you on the same topic, what we measure matters, and if you go to the next slide, we will speak briefly about why measurement of the built environment and health is important. I'll give you 3 examples from some work that we've been doing locally here in Atlanta and in Fulton County. The Fulton County work is incorporating some of the really amazing 500 cities data that CDC has put out recently, and then give you a very brief introduction to a study that involves youth around advocacy for physical activity promotion and the kinds of data that they will be pulling to help promote physical activity in their communities. And then I'll point you to some other resources for measuring built environment and health. Next slide. So when we think about health in the built environment as primarily planners who are tuning in today, much of what we influence through our work are the social conditions or the social determinants of health that have the greatest impact on health status. So you can see that that's at about 55%. This includes aspects of governing and the economy that affect health and health equity. So this may include issues of finance, education, housing, employment, all things that we deal with, and a number of things that we know have direct connections to what communities experience, and then how that relates to their health outcomes. So we as planners essentially operate at what is the health impact pyramid over on the right, at the bottom of the health impact pyramid, the part that is the greatest, that has the greatest population impact. And so the question that I pose to us today is, how do we better plan now that we know the power of our decisions on population health? Next slide. So we see a similar allocation of health determinants as reported previously by the Institute of Medicine on the previous slide. I'm sorry, the previous slide was the World Health Institute, World Health Organization. On this slide, we're talking about the Institute of Medicine, and they note that less than 30% of health outcomes are due to genetics and healthcare. And so this may be a surprise to many of you on the phone, or maybe not. But we do know that approximately 70%, and on the previous slide, if you added up the percentages, about 80% is the result of living and working conditions, economic and social opportunities, and the individual behaviors that those structural forces enable. And so we really are, in large part, shaping the health of our population, especially given the work that we're doing with Planning for Health here in the U.S. Next slide. So one way to understand how the environments that we create impact health of their residents is to look at mortality or length of life. So in Atlanta, where I am, if you live on the west side, you are more likely to die 2 to 3 years earlier than someone who lives on the east side, and a striking 12 years earlier than someone who lives in the north or the Buckhead area. In the Washington, Maryland, Virginia communities, some of you may have seen these images before. People who live in Virginia's Fairfax or Arlington counties, instead of the nation's capital about 14 miles away, are more likely to live an extra 6 or 7 years. Next slide. And then in New Orleans, the difference in life expectancies between the French Quarter and the Lower Garden District, only a few miles apart, can be as high as 25 years. 25 years. Data like this shows that something is happening, and that your zip code is really the better predictor of your health than your genetic code. Next slide. So if health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, and then let's go to the next slide, then we need to understand not just the events or outcomes, like death or mortality, as we talked about in the images from Atlanta, DC, and New Orleans, but also the behaviors that cause them, and the systematic structure of society, like transit access, food access, safety, community connectedness. These systematic structures cause poor health and create inequities, inequities across communities, inequities across the country. Next slide. So what causes these inequities through the systematic structures that we're looking at? And so what can planners, public health professionals, transportation, and other professionals do to realize equity for communities? Communities that sometimes are given an equal portion. With regards to resources for schools, perhaps an equal portion. Maybe we may even see equal resource allocation for transit. But these communities that are most in need do not get them where they are on a level playing field. So you can see in this image of the baseball field that the individual, the cute little kid who actually needs to see the game, he's not going to see it if he gets one little barrel to step on. He needs two, right? And some of our communities need 2 barrels. They need additional resources for transit. They need additional resources for community gardens. They need additional resources for healthy food access. And just giving them the same that someone else in another neighborhood gets won't help them realize the same outcomes that we really want to realize. And so the next slide is a quote. So following from the first presentation from Aristotle, in describing his ideal city, he stated that the best form of government is where everyone can act best and live happily. And then Benjamin Marsh, an early city planning leader, stated that no city is more healthy than the highest death rates in any ward or block. And so if we are to say that some of our communities or our neighborhoods are healthy, or star communities, or great places to live, we should really measure that against, as we see here from Marsh, that ward or block or census tract or neighborhood with the highest death rate, right? And so let's think about ways to make sure that we are operating and designing places that maximize the health outcomes and the benefits for the most vulnerable, and then that will help everyone, right? So the next slide just highlights some of the data resources that we began to look at as my group and others in the community here in Atlanta began to explore ways to develop local level data for our community that was not just looking at the planning information, and the built environment information. So we can see on the left, Neighborhood Nexus is a fantastic resource locally here in Atlanta. We have a number of relationships with them with Georgia Tech. They do not incorporate a number of health measures, and if they do, we only have access to them really at the county level. And then County Health Rankings has lots of great health data, but again, as we heard earlier, this is in large part at the county level. Next slide. And so what we decided to do is to develop what we've called the Atlanta Quality of Life and Health Dashboard. And so this dashboard measures built environment characteristics at the neighborhood level. We have 25 neighborhood planning units. Each planning unit has a group of neighborhoods, 3 to 4 to 5 neighborhoods. And the indicators in this project relate to a number of the fields that planners regularly work with, all of which interact with the built environment and health. Next slide. So we have 2 primary measures, the NQL, so the Neighborhood Quality of Life indicators, and those include amenities. So we measure green space access and retail mix, economy, housing, public safety, transportation. And so you can read on the slide what the different measures are that we put together for each of the indicators. And if you are to go to the website, it's easy to find if you Google Atlanta's Neighborhood Quality of Life and Health Project. You'll go to the interactive map and you'll be able to really just scroll around and explore all of these indicators as well as the individual measures. I'll also highlight that you can enter your address or an address or a zip code, and that will point you to the location of interest. And then the chart on the bottom right gives you a sense of what low, medium, and high socioeconomic condition neighborhoods exist across the city, and then what their relationship is to the indicators that have been selected. Next slide. So this one is our health indicators, and with the health indicators we look at 4 components. Nutrition, so the percent of residents with good food access. Physical activity, we use walkability as our proxy for that. Morbidity, and these morbidities include those that have correlations to obesity. And then mortality, with mortality is measured by years of potential life lost. And you can see in the map that is presented on the right, with the darker colors being the areas that are ranked higher. So this is a ranking of 1 to 5. Although what you have here is the walkability score, that the area of Atlanta that's most walkable is the darker area. And then you see kind of a morphing out to the west and then less walkable as you continue to go out in a ring to the west beyond that. And so this can give you a sense for where you want to direct resources, whether you're looking at walkability or food access or any other measure. Next slide. So once we completed this, we realized that we have 13 other cities or municipalities in Fulton County, and with Fulton County ranked 25 out of 159 for health in the state in 2016, we wanted to be able to provide a more fine-grained description of how the different municipalities compare to one another. Next slide. So this map just gives you a sense of the different municipalities across Fulton County, and everything from Johns Creek all the way down to Chattahoochee Hills, where they have awesome road biking for those of you who are bike riders. Next slide. And so this project was funded by the CDC. It's the Partnerships to Improve Community Health. What we've done as part of this project is to provide a platform to help improve community health programming. And you can see all of the partners who are involved. If you go to the next slide, this just highlights that the purpose is to provide free and open data that allows residents, community groups, planners, and policymakers to assess community needs, health needs, and develop data-driven strategies. Next slide. So this gives you a very quick look at the health measures that we've included. So we have mortality measures that are listed here, all of which are related to nutrition, physical activity, or tobacco. I'm not going to linger here because I want to give you a quick look at what the portal looks like. The next slide highlights the environmental topics. So this includes access and other built environment measures. And then the next slide highlights the livability measures that include many socio-economic, socio-demographic measures like race and age, as well as school quality and other housing characteristics. Next slide. So here you have a quick snapshot of the portal. You can go in and either create a map, you can put together a bar chart, bubble chart, spider web, or if you scroll down I'm going to ask Eliza to go 3 slides past because I feel like I'm a little long on time. So this one allows you to compare all of, or as many, variables as you'd like, either at the Fulton County level, so you can compare municipality to municipality. You can also compare district to district. That's not represented here now, but it's in our most recent update. You can also compare census tracts within communities and zip codes. Next slide. And so the final one that I'll talk to you about is this Youth Engagement and Action for Health. This is the only slide I have on this project. It's a new project funded by the Robert Wood Johnson Foundation through the Physical Activity Research Center. And what I wanted to highlight to you here is that, we know based on obesity data for youth that while the national prevalence for obesity is at about 15%, among Black youth it's at 20%, among Hispanic youth it's at almost 22%, and among Native American youth it's 40 to 51%. Depending on where you are, you could get up to 59%. And so physical activity and healthy eating are critical dimensions of ways to intervene with this community. And we want to go to the youth for them not just to tell us what they think the right things are to do, but for them to learn how to advocate for health. And so we use what is called the YEAH curriculum, a modified YEAH curriculum, Y-E-A-H, to do this with middle school youth that are in low-income communities and span minority populations. Next slide. So this is where I just highlight a quick resource for you. This is the Built Environment and Public Health Clearinghouse that was supported by APA, APHA, CDC, the National Network of Public Health Institutes. And if you go to project tools, you'll be able to find data and assessment, the tab. And then there's a number of resources here that includes the AARP Livability Index, CDC's Healthy Communities Checklist Toolkit, and a number of others, the Urban Health Index and others that I think many of the grantees will find quite helpful. And then Eliza, if you would just click over to the next one more. So this is Gapminder World. If you go up one, this is a neat site that you can use just to get a sense of general trends. And then the slide that we're on now is the 500 cities, and it provides data that you can both map on their interactive map, you can download the data and use it for your own municipality if your municipality is one of the top 500 cities. And you'll have 18 variables that include unhealthy behaviors, prevention, and then health outcomes, and you see the web link there. And so with that, let me say thank you for the time that you've listened to me, and I look forward to answering questions as we move on into the discussion session. Thank you.
Okay, hi, this is Kim Irwin in Indianapolis, Indiana. Good to be with all of you today, and I appreciate the opportunity to participate. We were fortunate to be in the first cohort of projects awarded through the Plan4Health initiative, and so I'm going to tell you a little bit about the work we did with an emphasis on the way in which we use data to help prioritize projects. So as I was introduced, you heard, hold on, let me try, make sure I can advance, there we go. So you heard about Health by Design in general. That's the organization that I'm with. We work throughout the state of Indiana to ensure that our communities have neighborhoods, public spaces, and transportation infrastructure that promote physical activity and healthy living. So literally we work at the intersection of the built environment and public health. And as many of you are probably aware, there are really 4 direct health impacts related to the built environment, so our transportation and land use decision-making. Those have to do with opportunities for physical activity, with safety, with air quality and other environmental aspects, and with access, whether that's access to medical care, access to jobs, access to healthy foods, all of that. And then around the circle are many other social determinants of health that are impacted by that intersection. So connection to crime and violence, again, environmental benefits, economic development, social cohesion and capital development, stress and mental health related to traffic congestion and auto dependency, and on and on. Again, it was mentioned under the Health by Design umbrella, we have 5 work groups, actually, 4 of them branded, focused on pedestrian work, on complete streets, on safe routes to school, and on transit advocacy. And then we have a general policy and advocacy work group as well. So the project I'm going to tell you about today, which was the focus of our Plan4Health funding award, and we couldn't have done the work without that support, is about walkways. And the Walkways initiative is specific to Indianapolis. The point of the initiative is to make the city, to make Indianapolis more walkable and to get more people walking. So that's about having a community that is safer, that's more accessible, and that's inviting for everyone. It was a partnership through our application. We worked consistently as a partnership between the city, the Marion County Public Health Department, and Health by Design. We have a long-standing history of working together, but this project provided an opportunity to really solidify that and to strengthen those relationships, which I'll talk more about. I'll come back to this, but I want to make the comment that Indianapolis and Marion County are essentially synonymous. We are a consolidated city-county governmental structure. And so differently than the Georgia example you heard, where there were about 25 or plus cities within one county, essentially Indianapolis and Marion County are synonymous. And we cover then more than 400 square miles, which does come into play. So within the Walkways initiative, our strategies, our key strategies were really fourfold. First, to develop a comprehensive pedestrian program within the city, to develop a pedestrian master plan. There had never been a formally adopted pedestrian plan for Indianapolis prior to this work. To develop and execute a community-wide campaign to actually promote walking and to get neighborhood advocates and community members more involved in advocating for walkable communities. And then we also have some work specifically related to pedestrian crashes and where they happen and the designation of safety zones. And that work is separately funded and ongoing, but is a part of the overall Walkways initiative. I want to acknowledge our partners at Nelson Nygaard Consulting as they helped to develop the pedestrian plan. So the plan itself, the purpose of the plan was to create a long-term vision for a more walkable and healthy Indianapolis. And you note there that health was, again, part of that, part of the goal, or an intended goal from the outset. We also wanted to establish a process for making data-driven decisions using clear, equitable data that would guide investments. And that is because we recognize the resource constraints that we have and need to ensure that every dollar we spend on infrastructure is spent in the wisest way possible. This slide speaks or gives you really a demonstration of that. So when we went into the pedestrian planning process, the city had an estimated need of $750 million to do all of the projects that were, again, known related to pedestrian improvements, whether that's building sidewalks, improving intersections, doing crosswalks and ADA ramps and all of that. $750 million of known need. I will tell you that at the conclusion of this project, we actually think that that's probably only about half of what the real need is. So well over $1 billion of need that's clear. And currently, our total transportation budget for the city, so not just for pedestrian infrastructure, but for roads and bridges and transit access and walking and bicycling, totals $50 million. We think we really only spend about $3 million in a dedicated way on pedestrian infrastructure each year. So to that point, again, the part of the purpose of the project and what we're setting up for broader implementation is using data and thinking about how we make decisions about where we spend money. Skip that slide. Public engagement was a very important piece of the puzzle for us, and was important for us to get input in a variety of ways. So we had a trade-off survey, and it will not be easy to see there, but that first slide with the $10 is basically asking people how they would spend $10 on sort of what at times might have seemed like competing interests, but weren't always. We did more of a fun thing with a community cinema and open house where we showed some films related to walking and had more interactive display, and then had some more traditional public input opportunities as well. And again, in establishing the vision and goals for the project, that idea of health and safety rose to the top. I always like to point out the fourth goal, to get it done, just because implementation is key. We all have example after example of planning that's done great, planning that's done, but that doesn't get implemented. There's not money committed to getting the work done. And so we wanted to make sure we were thinking about that on the front end. A state of walkability report is essentially a companion piece to the final pedestrian plan. And again, that's what allowed us to really look at what is the state of walkability in Indianapolis at the outset of the project. What are we spending, as I alluded to? What does the infrastructure look like? What are the needs? What are the considerations we need to take into account? So the next series of slides I'm going to go through really dig into the data that we used and again in determining that prioritization process. So health was a key aspect, as I have said. So what we did, and you'll see this for, again, the next few maps, is take multiple factors and put them together, essentially composite maps then. And so this, for health, we were looking at overweight and obesity, we were looking at diabetes, we were looking at access to groceries, parks and greenways, and then we factored in safety to this health map as well. We also looked at equity factors, looking at minority status, poverty, age, limited transportation options, limited English proficiency, and people with disabilities. And so again, all of those things were combined to help us understand where people were living within the city, county, that might have more need based on those factors. I want to take a minute here to toggle back to the last map and ask you to just look at the scale of sort of the blocks of colors there. So this map with health data was done using health planning areas, whereas the equity map was based on census data and so gets down into census blocks. And so one of the limitations, which we'll get into I'm sure later, but is that geographic area represented by data or that's available really can make a difference in terms of how you're able to use that data and how granular you can get. I'll also point out, just looking at this map, and you'll probably get a sense of it as I go through, that Indianapolis, given its 400 square miles, has a lot of diversity in the land uses and the community context. So our downtown is one of the most walkable, vibrant places in the country. And if you've never been to Indianapolis, I want to invite you to come here and visit. It's really fantastic. But we also have cornfields and farms within the county, horse farms. We have what most people think of as their city's suburbs are within the city limits. And so that adds additional considerations, and it is just the reality of what we deal with in terms of that. So safety was another key aspect of decision making. We looked at high pedestrian or pedestrian crash areas and high collision corridors. So this map shows you both the density of collisions, or where they're happening, but also has a factor built in for severity of collisions. And those areas marked that are a deeper, more brown, and that are marked with the black outlines that are the areas that are most critical in terms of safety. One thing that we do as part of the ongoing pedestrian safety analysis work we do is walk audits. So we've done literally dozens of them over the last few years, and always when we can try to include community-based partners. You can see here a number of law enforcement officers. Our health department is represented there, our local Y, and other community-based groups. And so bringing people together to go out and literally walk around and look at what the streets look like is a key aspect of understanding that context. And again, that was alluded to earlier. You can't just do this work behind a desk. So then within the mapping, we also looked at more traditional data that you might assume for pedestrian plans. So things like traffic volume, speeds, how many lanes, where sidewalks are available or not, lighting, and use that to essentially come up with a level of comfort for walking. And then we overlaid with that pedestrian generators, so the areas where you would expect people to be walking based on the density of employment, on residential, access to transit, and then proximity to other things like schools and parks, retail nodes, that kind of thing. And then lastly, we factored in several city priorities, we called them. So these are kind of more qualitative issues, I will say, even though there was quantitative data to use, but that got at some other key political initiatives or reflected other important factors in the city. So we have a lot of transit work going on, and so transit-oriented development station areas came into play here. We have an initiative reconnecting our waterways to reclaim our waterfronts and make those more accessible and to connect them with active transportation. We have some high crime investment areas where resources are being targeted. And then this catalytic neighborhoods is really based on like a market value analysis where we're looking at neighborhoods that have opportunity where investment would help to stabilize and or improve them. And so then when you take all of those maps, which again reflect multiple different data sets and factors, and you put them all together, you end up with a prioritization map, which I will show you on the next slide. So here's where you see the maps all being layered together. And just note to the side, the 3s, 2s, and 1s, we did use a weighting factor that, again, may ensure that the safety, health, and equity data was being prioritized within the process. So then you end up with the prioritization map. We ended up using 3 tiers. It was extremely important to make the point that nobody everybody is important, right? There's no part of the city that isn't important when it comes to the need for pedestrian infrastructure. But these dark blue areas, the darkest blue areas, are the ones that, based on all of those other data points and factors, are where we should, where the process tells us we should be investing. What you all realize, though, no doubt, and you'll see here in a moment as well, is that even within those areas, there are still thousands and thousands of potential projects. And those projects look different ways. Improving walkability isn't just about building sidewalks. It's about ensuring that people can get across the roadway. It's about having trails and off-street facilities that people can use. It's about making sure that we can get across not just major streets, but rivers, and we don't have mountains here, but if you did, mountains, and that kind of thing. And then the element of placemaking, which brings people together and creates the types of environments where people want to spend their time. And so, again, it's an oversimplification to say, oh, we just build sidewalks in these places, and we wanted the plan to reflect that. So, again, mapping all of the city's sort of known projects, all of the potential projects, you can see it literally covers essentially every major roadway, every intersection within the county, and again, it reflects thousands and thousands of projects. When you then overlay those high priority areas, you can begin to narrow that down a bit, but still end up having many, way too many projects than there's money available to do. So what we did at this point was go back out to the public and ask them to help us think about a second phase of prioritization. How do we take, again, literally, I think this reflects about 2,500 projects in the darkest blue area. How do we start deciding, even within a high priority zone, how you pick one project versus the other? And so, again, getting public input, you can see this activity with cards that I'll talk about a little bit, but essentially what we did was identify then additional factors, which do tie back in some cases to the original things we looked at, that allowed for a second level of prioritization. So those those include, again, access to transit, access to nearby destinations in general, schools, parks, retail centers, things that enable active living, so they're within proximity of a farmer's market or, again, a park, that kind of thing. Looking at different land use types, that idea of barriers and filling gaps. And then we also, and this is much more subjective, but wanted to leave room for flexibility in this, which is key in order to ensure that it actually gets used. But that then it allows things like leveraging other funding or piggybacking on existing projects, as well as favorable conditions, which could be, a neighborhood group that is willing to contribute money, or an area where there's absolutely not public support might fall off the list. So when you add that second framing in terms of thinking about what it does, we were then able to essentially narrow that list down even further and identify the top 100 projects that the city would begin addressing in order to, again, start to chip away at that magnificent need to improve walking and walkability. Within the plan itself, there were then about 40 additional recommendations beyond the infrastructure projects, looking at programs, policies, and procedures, those day-to-day practices that result in, again, just how things get done. And so I encourage you, if you're interested, to take a look at that. All of this is available on the Indy Walkways website, which is indywalkways.org. There's a planning tab. So just to close, a few of the lessons, and I've touched on this a little bit, but this was an incredible opportunity for us. It allowed us to get done the plan in a way that we otherwise wouldn't have, and to build some other aspects of the project or to develop those aspects of the project that live on in an ongoing way. It certainly allowed us to strengthen relationships between the city, the health department, and community-based partners such as Health by Design and all of our coalition members. it really gave Health by Design legitimacy with key leaders and decision makers. We've just celebrated our 10th year last year, and so we've been around and we've worked with people, but our ability to bring resources to the table, you know, it's that sort of, I'm using air quotes, but public-private partnership allowed the city to get something done that they wouldn't have otherwise been able to do in that time frame. The process itself, in terms of pulling data, using data, thinking about data, helped to institutionalize some other practices that we're continuing to do and follow. And then it just opened up a broader discussion and allowed us to dig into data in a way that facilitated transparency and provided the opportunity for us to do some benchmarking that otherwise hadn't been done. Certainly every project has challenges, and those are the things we learn from. The timeline was aggressive, which is often the case with grant funding, and that's fine. We were able to accomplish most of what we set out to do, and are fortunate to be able to be continuing to chip away at others. We did have a change in mayoral administration in the middle of this project, and we knew that that would happen going into it, and we're able to take some steps to minimize that impact. But certainly the political climate, literally the people who within the city structure who are our contacts, you know, we were constantly trying to just ensure that we were managing that part of it. A project like this, and again, a lot of this work in general stretches the capacity of partners. Not everybody is able to incorporate this in their day-to-day efforts, and so we learned some lessons around that. And then, as I spoke to specifically around like the level of detail of data, we again certainly realized some of the limitations that, you know, when you work generally with data, you know there are limitations, and then when you do a project like this, you get really detailed into what those limitations are. So in addition to the scale issue, we learned that a lot of our self-reported data, so the health department had done a health needs assessment relatively recently, and a lot of the self-reported data didn't actually end up matching up with what like GIS data showed us. So what mapping was telling us about proximity to parks or retail or food access didn't necessarily align with what people generally were telling us. So the data is fun, and it gives us lots to work with in terms of not just taking it at face value, but then working beyond that. And I think, again, as it was said earlier, thinking about, you know, what else does that tell us, and how do we use that to advance the work more broadly. So with that, I will stop. Please reach out to me if you have any questions, and I'll turn it back over to Eliza.
Thank you so much, Kim, and thank you to everyone, Rachel and Sandra, and Nisha, Dr. Botchway, and Kim. Now, this was really fabulous. It's really exciting to look at all of the different ways that we can leverage data as we're, you know, trying to build healthier communities. So I'm going to pass things back to Rachel and Sandra to kind of tie some loose ends together, and then we'll just kind of open it up for discussion and questions. So start thinking about what you want to ask the panelists.
Thank you, Eliza. This is Rachel Bennett at Prevention Institute, and thanks so much to Professor Botchway and to Kim for sharing about your work. I think all of what you just shared really are some great models for us all to be thinking about, to be drawing upon in our own work. So really do appreciate that. I just wanted to elevate a couple of things that really resonated with Sandra and me over here. One is that it really is, I think, a foundational skill and capacity for planners and public health folks and everyone who supports the Healthy Communities movement to be able to tell a compelling story about the value of the way that we work, the value of our goals, our objectives, and the data is such an important tool in telling that story. So Kim, when you mentioned about what the current budget is in the city of Indianapolis and what the estimated need is. Data can help to tell that story. I think what we don't often talk about, and what I want to lift up here, is that we, as healthy planning folks, need to be able to sit down with those budgets and look through and understand what the need is, what the allocation is, and how we can help to close that gap through effective storytelling, through strong policies, through programs, through community engagement. So that's one thing that I wanted to lift up. Another, and this will sort of turn into a question for the panelists, is to think about, once we have those practices, once we have our data sets and our maps and our community engagement, and we have great projects on the ground, how do we then institutionalize that great work into practice change, so that it's not just one great grant-funded project, but that we're actually changing the way that planning or transportation or public health is working in the future. We know what's working well. How do we institutionalize that approach? So I think I would love to start off with a question to the panelists before we open it up to everyone, and ask about what you think is really needed now in the healthy planning movement to move from those project by project, grant by grant approaches, and fundamentally change the way decisions and investments are made, so that not just the healthy choice is the easy choice, but the health promoting policy is the policy that gets passed. The health promoting investments are the ones that get made first and most intensively. It may be communications, it may be data, it may be engagement, it may be practice change. I'd love to hear, here we are in 2017, what's the next thing for our practice?
This is Kim. I can...
Go ahead, Kim.
Sure. I'll just jump in quickly, and I don't think I have a great answer for this. What I will say is that we're really fortunate, again, and appreciative of the additional work that's going on through Planners4Health from APA to be able to start exploring that more at the statewide level here in Indiana. Because, again, we've got some of the immediate lessons and some of the things that we just know from doing this type of work, but it's going to give us the opportunity to hear from practitioners, particularly in more rural parts of the state, and folks that aren't already doing this work, to give them the chance to weigh in on what are the barriers, what help do they need, and what will it take to do that. So I'll pause with that.
Thanks for the question. I think there are a number of ways that we can institutionalize health and decision making for planning, as well as incorporate planning dimensions and criteria in the work that public health folks are doing. I'll share that a couple of years ago, maybe 2 or 3 years ago, my colleague Catherine Ross and her group from the Center for Quality Growth and Regional Development led a process for Plan4Health, which is our kind of regional plan put together by the Atlanta Regional Commission. And as part of the resource for Plan4Health, which essentially was the big project with it was a large health impact assessment, but the very useful deliverables were guidance on how to incorporate health in their day-to-day operations. So what I would say is the best approach to institutionalizing health evidence in planning decision-making is to incorporate health as part of the scoring for projects. Health as one of the measures for considering where a sidewalk goes, much like the tiered system that was presented earlier, which I thought was fantastic. How do we incorporate those measures in what we do every day as planners? The other thing that I would say is a really fantastic opportunity are the community health needs assessments and community health improvement plans that nonprofit hospitals and then planning and other agencies need to do. So the community health needs assessments are very useful in that these nonprofit hospitals are trying to figure out ways to promote better health in their communities. And many of the plans that we have for our neighborhoods overlap with the areas of interest by these nonprofit hospitals. And I think they, in large part, would appreciate having some input from local planners on ways to leverage additional resources and stretch their dollars to have a better impact.
Great, thank you both. Eliza, I'm going to hand it to you to start engaging some of the participants and reading some of the questions that have come in via chat. There's some great questions coming in.
Thanks, Rachel. Yes, there are quite a few questions coming in, and we also have somebody who's raised their hand. So Jacqueline McRae, I'm going to go ahead and unmute you if you want to ask your question over the phone.
Oh, I'm not on the phone, but I did type my question in.
Oh, sure. Okay, I can just read it. So let's see. Jacqueline is asking, what are some good practices for balancing and blending quantitative data with the qualitative realities and stories of people in the areas being studied?
That's a great question. So I'm going to give you an academic answer, and hopefully Kim will give you an on-the-ground answer. So from the academic side, I think, and I'll rely on photo voice that was highlighted earlier, I think maybe by Rachel, as a resource that one can use. So with photo voice, individuals or video voice, individuals that capture those images will write a summary about what it means to them or what the story is about it. And then you can use quantitative data to tag to whatever that issue is. So they may be talking about sidewalks that are not complete, and you may be able to pull data on complete streets or investments in sidewalks in your community to kind of highlight the higher level quantitative measurable that goes beyond the storytelling. And then I guess the other thing that I would say is being able to look at policies. So policies such as the Neighborhood Stabilization Program, for example. And then and you might have someone do research on the areas that are receiving neighborhood stabilization dollars, and then look at other dimensions of those communities, such as housing vacancy, asthma admissions, and other measures to see if there are particular concerns based on those different areas that are receiving or not receiving neighborhood stabilization dollars that may be related. So, so I think there are many ways to connect qualitative to quantitative, and you don't need to have a robust regression analysis. In many respects, you just need to have a couple of numbers and percentages.
So this is Kim. I think one of the ways that qualitative data can be used is really at the starting point. I think a lot of the work that or some of the work I'll say that we have identified over time are the needs that the issues that we have that we need to work towards resolving have resulted from the stories of people at the neighborhood level, people who have had experiences with, say, being struck or nearly being struck by a car. And I think that particularly there's a lot of work that we're trying to do right now around process, again, systems things within public agencies, within city government, and data use is one of those. But so having the examples of sort of where breakdowns occur or why it looks differently on this street versus that street, or something different was said at this neighborhood meeting versus that neighborhood meeting, really gives us a lot of times a good starting point for digging deeper into problems that then may have, may need quantitative data to better understand what's going on. And then I think beyond that, as was said, like having stories, having the qualitative aspect to share with policymakers then really, truly puts a face and a name to the reality of the numbers. And so I think that both are critical to the overall effort.
Thanks to both of you. And just a quick follow-up question on the qualitative data pieces around the tagging and coding and analysis. Is that via in vivo or another software?
It really depends on the capacity of the organization that's doing it and the amount of qualitative data you have. We completed here in Atlanta for the city of Atlanta their comprehensive development plan in 2011 included 800 surveys, of which there were maybe 4 open answer or open-ended questions. It's about 1,200 open-ended responses that we needed to code. So for that, we used in vivo. But if you have that volume of responses, you could also just make sure that you ask a very clear question and limit the amount of text people can use to respond, so you can have an easier time coding their responses. And then you just do keyword searches. That may take less time if you ask a very clear, specific set of questions.
Great, thank you. Another question that came in is really around rural communities and thinking about what a health dashboard to track progress in a rural community might look like and how metrics might differ from an urban area.
So that's a great question. I'll take a stab at it. And we've been really challenging ourselves with how to expand what is right now a very urban-focused set of resources that we've developed, and knowing about the fantastic resource from the 500 Cities Project from the CDC and RWJF. Presenting data in a rural environment is really challenging, in large part because you have smaller numbers of people spread out across space. And that's especially challenging for health data. I think a general response is that a dashboard for a rural area could look very similar to a dashboard for an urban area. We would just need to customize the variables based on those that, one, you want to be able to compare from one community to another, and one community density to the other community density. But also, what are the specific goals and interests and perspectives of the rural community that you want to emphasize. So dashboards don't all have to look the same, but it is useful if you can have some comparables across space.
That's great, thank you. Alice, oh, sure, go ahead.
This is Kim. Sorry, do you want me to weigh in, or do you want to move on?
Yeah, absolutely, if you have.
Okay. Yeah. And just a quick comment, and I'm not sure that it necessarily gets at what was being asked, but hopefully, and that's that one of the things that's really important to understand about this work, too, is how, I'll say, boring is not the right word, but like how sort of small the measures are around change occurring. And so the example I'll use is complete streets policies, right? So when it first occurred to me that we are measuring progress of complete streets policies literally by the number of policies, and that's 2, right, for maybe in a given year, or 4 in a good year, or whatever that looks like in your community, that that is the measurement of progress. And policy change, systems change, those types of things, you know, you don't measure in the same way we're used to thinking about metrics. And so at least for me, it was a shift in thinking, and that those process measures and that get at the change we're trying to see, but that do look very different than, or could look very differently from an urban to a rural area, I think is another part of it.
And let me jump back in and say that's a great answer. I'll extend it by saying that we're working in some rural communities with the Youth Advocacy Project, and in our attempts to get at policy systems and environmental changes, we are conducting interviews with decision makers and the adult leaders that are leading the youth in this YA curriculum, the Youth Engagement and Advocacy for Health curriculum. And it's through those focused interviews that we are teasing out these processes that are impacting policy systems and environment. And so I echo the previous answer that some of these things are hard to project on a map or a chart. And in some cases, they just need to be a list of before and after.
Thank you. And Alice, I see that your hand is raised. Do you want to go ahead and ask your question over the phone?
Certainly. So I actually don't have a question. I have comments about the how to add health and decision-making discussion that we just had. A couple of things that I think are some of the basic things that I find as a healthcare administrator that people in the community planning world often maybe take for granted, but I feel has been really, really important with advancing the work that we've done here in our community, is something as maybe simple as the wording of health and well-being in the county planning vision and mission statements, as well as in the vision for transportation plan that when that's developed. So just by including those words in those documents gets people to start thinking about including that into the next step of criteria for projects. And if you have smart growth grants and the criteria for applying for and administering smart growth grants, that those health and well-being criteria is included in those. And I just often find sometimes that's taken for granted, which is the step that sort of gets us to the next level. Also, the other thing that I find that has been vital for us is to include or do as best you can as getting a traditional health person on your planning commissions. So what I mean by traditional health would be a doctor, a nurse, someone that understands the connection between planning, the built environment, and health, but has those titles, because it really makes people that traditionally wouldn't listen to what planners might say. If a doctor starts saying that these changes are going to help improve the health and well-being of my patients, it seems that people start listening a little bit more in a strange and unusual way. So really advocating to get someone like that, as opposed to a public health, someone that they typically see as advocating for public health. If you get some what I would call unusual suspects for at least the next few years, it seems like they would still be considered unusual. The other thing is I would encourage people to link to population health strategies from a health system standpoint, as the health systems are moving in that direction where they're looking outside of traditional sick care into population health, but to link into that as best we can. I think that's also how you can maybe recruit some physicians and nurses. And then the last comment that I have is around the measures. I loved it when the discussion you just mentioned about complete streets policies. The other thing we look at measuring when we think about complete streets or implementing any type of policy similar to that is we also measure the people who would be potentially impacted by that policy. So if that policy goes into play and they start implementing some of those strategies with it, no matter what they would be, with the complete street, sidewalks, connectivity, any of those aspects of a complete street, you're impacting a certain amount of people within the community. So we also take some credit and sort of, put a little disclaimer on that, okay, it's not all of the people, but there's the potential to impact according to like the socio-ecological model, that policy alone could impact many, many people. Thank you.
That's an excellent add-on. Let me say with regards to complete streets that one of the parts that I think is missing in measurement for complete streets is the before and after counts of pedestrians and cyclists. So when we've looked at some of the complete streets projects out in California, it's been very challenging to see what the impact has been of these completed projects because we don't have a good data source for pre and post ped and bike activity. But we do have, interestingly, good data on injuries, right, and fatalities pre and post. So as projects move forward, being able to have those counts is critical, and to have the unusual suspects, and hopefully the doctors and the public health folks become usual suspects on planning commissions and city councils.
Thank you, Alice, for that great question. It looks like another question came in around thinking about what sort of measures and metrics you are using to track whether interventions are leading to improvements. And similarly, what measures to assess your success, given the struggle with using chronic disease interventions, which can take years to manifest, and difficult to determine, what actually led to a positive result.
So I'm happy to jump in and forgive
I'm happy
me.
to let you.
Okay. So I'm going to put on my public health hat and say that the best way to answer that is to put together a logic model. And a logic model essentially tells you what your inputs are. So are you putting in particular resources? Who's being impacted? Just what are the inputs for the project? What are the outputs and what are the outcomes? And the outcomes are these short, mid, and long-term approaches. So that long-term would be the chronic disease. The short-term may be numbers of people walking, right? And so it really just depends on what the project that you're looking at is focused on. APA has really fantastic resources in the planning and health area, some PAS reports that highlight the use of logic models. The Built Environment and Public Health Clearinghouse, which is one of the slides I highlighted with the data resources, they have resources on logic models. And I'm happy to direct folks to additional resources if you email me. But there's not a set of things that you measure. It really just depends on the program that you're designing.
This is Rachel Bennett over at Prevention Institute. I wanted to underscore the importance also of data here. Obviously we do need to measure what is an effective intervention, but I want to encourage everybody to think even more broadly about what effective means in that case. I think one of the things we've seen in the Healthy Communities movement in the last 10 or 15 years is that what we think of as success can have unintended consequences. So for example, if we're doing complete streets projects or parklets, we may measure health outcomes or place-based factors that have changed over time. So you see that there was very little access to parks or to bike lanes in the year 2000. Then after our interventions in the year 2010, suddenly there was much greater access. Similarly, we can see in our population health data that there were certain physical activity rates that were low in 2000. By 2010, they were higher. Obviously, that is the trend that we want to see. But we also need to pay attention to who is benefiting from those investments. It may be that one of the unintended consequences of these health promoting investments is gentrification and displacement. and that maybe the folks who really could have benefited most from those investments in the year 2000, by 2010 could no longer afford to live in that neighborhood. So I realize that that's adding a whole other layer of challenge into data collection and into ensuring what we do works. But I do think it's really important for us as a field to be thinking about not just what do we measure and how do we measure it, but how to account for some of those unintended consequences.
And this is Kim, if I can just pipe in briefly as well, not to absolve us of the responsibility for evaluating what we do and tracking that and measuring it, but I think we also have a role in helping to shape and reshape the conversation about, frankly, reasonable expectations of intervention success and effectiveness. Because the reality is you don't build a sidewalk and see a decrease in diabetes rates the next year, right? We all know that on the phone, but it's not everybody does understand that. And so I think it's also part of our work to, explain how complex and multifactorial these issues are, and to help reshape some of the expectation that we can't, the way a lot of funding has worked in the past, it's been tied to very short-term outcomes, and it hasn't necessarily been effective. And not all funders or not all, whoever leading organizations have caught up with that shift. And so I think we just have to be aware of our role in that part of the conversation as well.
I'll add one more resource, and that's the Health Impact Project that's supported by Pew Charitable Trust. They house the library of health impact assessments that have been completed in the U.S. And I think those of you who are trying to answer the question, well, what do I measure? I'm not sure what I measure. I encourage you to take a look at their portal. So if you just Google Health Impact Project, you'll be able to find their HIA resources. There's a map that you use to navigate through. And you can identify types of projects, and then based on those completed HIAs, just go to the assessment section of the HIA and see what measures they collected, what measures they think are important to collect for that type of project that might be similar to your project, and mirror that. You don't have to reinvent the wheel, just figure out how someone else created the wheel and redo it in your area.
Thank you. I'm going to pose another question, and it might be our last question, so I will just say a couple of things were coming in with around specifically either the work in Indianapolis or in Georgia, so I encourage you to follow up with me at APA or our panelists, and I'm sure they'd be happy to answer your more specific questions. But another question for the group is, what are our strategies as planners and policymakers for developing partnerships with capital agencies such as utilities, transportation, who are making huge investments but may not be thinking about the social determinants of health?
This is Rachel. I can start. I think that it is incumbent on us as healthy planning folks to start where people are at, and for us to take on the responsibility of really understanding their process. How do they work? What are their goals? What are their objectives? What are their pressure points? Where might there be political opposition or opportunities? Again, sort of thinking about those levers of opportunity in order to understand the conditions we're working in, whether it's transportation or utilities or development. When we think about that broader group of folks, Professor Bochwe had mentioned going beyond the usual players. So when we think about going beyond the usual players, we need to first understand the landscape that we're operating in to understand where there are opportunities to embed health. So I think that's an extra challenge for all of us. It's really going beyond our own expertise, but there are lots of opportunities there to understand how those funding channels work, what those policies look like, who the key players are, and who and what might be receptive to health, equity, and safety concepts.
And this is Kim. I'll just add, and I probably didn't say this, but I think one of the things that made our project most successful was that we had active and consistent participation from several people from our Department of Public Works transportation area throughout the process. And we've had those relationships in place, but again, this project and the process itself and their willingness to keep coming back to meeting after meeting and, you know, to do the things that were part of it was a tremendous help, and we will absolutely see the benefits of that far beyond the plan itself.
Great. Well, I know we're at 4:30 Eastern time, so in an effort to honor everyone's time, I think we'll wrap up here. Again, for unanswered questions or if anyone is interested in continuing this conversation, you can always reach out to us at APA, and we can connect you as needed, or you know, hop on the phone and continue the conversation. And we hope to do that as well in the Planners for Health monthly peer calls for March in a couple of weeks. So on behalf of APA, I just want to take a moment and thank again Rachel and Sandra from the Prevention Institute, Professor Bochwe and Kim from Indianapolis. This was really fabulous, and I think, you know, it's exciting seeing all of this great work happening around the country, and we're going to keep on making progress and sharing what we know with our peers. So thanks again, everyone. Have a nice afternoon.
Thank you all. Thank you, everyone.
Thanks, everybody.
Bye.